Hello, everyone. Today, Patients Like Me is partnering with the NIH's All of Us program to sponsor this webinar about COVID-19 and the importance of diversity in clinical research. I am Dr. Kate Burke, Senior Medical Advisor here at Patients Like Me, and I will be moderating today's event. I am here with Dr. Laṣé Ajayi, Director of Diversity Initiatives and Clinical Researcher at Scripps Research. Dr. Ajayi, can you please tell us about yourself and the work that you do for the All of Us program?
Absolutely. So, as you said, my name is Laṣé Ajayi. I am both a pediatrician and a palliative care physician, and I'm the Director of Clinical Research and Diversity Initiatives at the Scripps Research Institute. Within the All of Us project, which hopefully all of you are aware of as being partners, I also work on the pediatric playbook to try to enroll pediatric patients and serve as kind of the clinical director from the Scripps Research side as we enroll participants into the All of Us program.
Fantastic. So Dr. Ajayi, we have had some of our members ask questions for this webinar today. Can you tell us why it is so difficult to get qualified for clinical research? And can you speak to us about that?
Absolutely. I think if I'm understanding the question correctly, the question is really asking, why is it so hard to get clinical research off the ground and approved? If that's right, the biggest hurdle, honestly, is because you have so many people who need to come together and play in the same sandbox. Clinical research takes a lot of cooperation from a lot of different people, different stakeholders, if you would. So you have the person who's going to sponsor the research. That could be from industry, academia, government, patient advocacy groups. And then you have the clinical investigators themselves, the participants, payers from insurance, physicians, the researchers themselves, and the list goes on. So then you have to take into consideration the time it takes to get all these people aligned on the same page, make sure their interests are well addressed before you can even start the study. Then you also have to make sure the funding agency thinks that the question you're trying to ask is important enough to push it up the pipeline to even start your study. So while the stakeholders may have a brilliant idea of what research needs to be done, somebody actually has to find your research important. So the biggest bridge you then have to kind of cross after you get that everybody on the same page, you get funding, you're started, is then how do you take the the clinical findings from the clinical trial and apply it to the bedside? So all of this takes so much time and so much coordination. You can imagine why it takes so long for actually a clinical study to get off the ground and then the results to be applicable to the patients at the bedside.
Yeah, thank you. Can you talk about diversity in clinical trials and why this is so important?
Absolutely. This is a huge, huge passion of mine. The short answer is that clinical trials and clinical research make up the basis of our standard of care. So as a pediatrician, as a palliative care doc, I rely on the results of clinical findings to drive the care that I give to my patients. Research and clinical trials are how we determine appropriate dosages, side effects, drug interactions, and make the necessary calculations for life-saving decisions in medicine. So really, clinical trials are how we determine patient care. If there's no diversity in clinical research, it means that we're basing the standard of care based on a very narrow patient population. And these standards that we develop affect patients like me in a very real way. So think about maternal fetal health, which is one of the research that I work on. Pretty much maternal fetal health affects every known demographic you can think of. Women from all walks of life can get pregnant. Yet really a lot of the recommendations and standards that we do in OBGYN comes from predominantly middle-aged Caucasian women. So then we're taking the results from those studies and those clinical trials and trying to apply it to make everybody else fit into those boxes. So you see, we as scientists and researchers and physicians create these standards, we get stuck with them, and it takes time to change them. We have to redo new studies, and when we redo these studies, we need to have more diverse patient participation. Otherwise, we're not going to have diversity in the care that we give to our patients. We're kind of stuck. And the fact that we rely on these standards of care is also a big part of why there's institutional racism or systemic racism in medicine. It's because we don't take into consideration diversity within these clinical trials. So I actually have a slide that shows what that participation looks like. And I'm going to take a moment to share my screen so you can kind of have a pictorial image of what participation looks like.
Okay, that sounds great. Thank you.
Of course. And tell me if you can see the slide.
Yes, yes.
Okay.
Thank you.
Absolutely. So according to research from Clinical Research Pathways, they're a non-for-profit organization focused on increasing diversity in clinical research. African Americans make up only 5% of clinical trial participants, despite representing over 13% of Americans in the United States. This disparity is even more extreme with Hispanic and Latinx communities. Then you take into consideration First Nation populations, and this doesn't even include LGBTQ populations in clinical research. So the data we collect shows that, honestly, minoritized groups are really woefully underrepresented in clinical research. Diversity within participants in clinical research is important, but you also need diversity in the people who are conducting the studies themselves, right?
Right.
Because of like historical racism and mistakes that scientists have made in the past in people who volunteer or were involuntarily enrolled in clinical trials, there's a huge mistrust in sign up for clinical trials. So having someone that looks like you conduct the study actually makes you feel a little bit more comfortable and trustworthy of that study, and you're going to feel more likely to participate. But when we look at diversity within clinicians and people who do research, you can see again, it's really small. So you have about 4% of Black and Hispanic physicians within the workforce. And then when it comes to NIH researchers, it's even less. Only 1.5% of Black and African Americans are funded by the NIH to conduct clinical trials. And it's a little bit higher, 4.6% in the Hispanic community compared to the huge disparities we see in the Caucasian population.
Thank you.
Absolutely.
Thank you. Now I have a question about vaccine development. How did clinical trials play a role in the vaccine development for COVID-19? Was there a greater effort to include people from marginalized and minoritized backgrounds?
Yeah, that's a great question. So simply put, without clinical trials, the vaccine would never come to be. You have to make sure you're as safe as possible with the least amount of side effects for the largest population when you're doing vaccine development or really any drug development. So when we look at vaccines in general, like the most common vaccines, measles, mumps, flu, typically vaccine development takes about 10 to 15 years to actually develop, particularly when you're looking at a class of pathogens when there's no licensed vaccine already. So from start to finish, when you're starting from scratch, like we did with COVID, it would typically take us 10 to 15 years. Now, it's not to say that because we were so fast with COVID, we cut corners with the clinical trials. It's actually, it takes that long because a lot of bureaucracy. So looking at how fast we developed the COVID-19 vaccine, by October 10th of 2020, there was already 92 vaccines in the preclinical evaluation, right? More than half of those were in phase 1 and phase 2 of the safety trials. 11 were in phase 3, meaning that we're actually seeing how well they worked. So phase 1 and phase 2 really looks at the side effects, the lowest dose you can use to have the biggest effect, and then how effective it is. So really by the end of 2020, we actually, as you know, had some that were working in the UK and the United States. So we ramped up, and vaccine development for COVID-19 was so fast because we had so many people working together for a shared common goal to address a global pandemic, which we really haven't seen that type of cooperation and coordination in quite some time. Now, with effects to recruit minoritized groups in the vaccine trials, I will say a lot of researchers, particularly within the United States, have worked really, really hard to improve that process. I think we know that in order to really end this pandemic, we have to pay attention to the people who've been affected most. If we don't pay attention to those people and include them in the vaccine trials, then they're not going to want to use the vaccine. We're not going to know how effective it is for them. And so researchers have actually looked to meeting Black, Hispanic, Native Americans kind of where they are, looking at recruiting from churches, et cetera, to make sure that we can include them as much as possible. That said, how many still enrolled in these trials? Not as much as we would like. And again, it's because of a lot of the mistrust within the scientific community because of past transgressions.
Thank you. Now, speaking about COVID-19, let's dig a little deeper into this topic. Can you go into more depth about how COVID-19 is disproportionately affecting people from marginalized and minoritized backgrounds? And what exactly does this mean?
Yes. So for this one, I thought another slide would be helpful. I'm going to share my screen so you can see this. So this is data. You're able to see this, Dr. K?
Not yet.
There we go. How about now?
There we go. Perfect.
Excellent.
Thanks.
So this is the data that we had as of November 2020. So you can see that compared to non-Hispanic Caucasian populations by age, and this is from the CDC, age-adjusted case rates by state and territories, you can see that American Indian, Alaska Native were almost 2 times more likely to contract COVID-19. This is huge, more than 4 times likely to get hospitalized and over twice as likely to die from the disease. From our Asian and Hispanic patients, they get at about the same rate as our Caucasian counterparts, 1.2 times likely to get more hospitalized, and a little 1 over time to die. When we look at our Hispanic and Black populations, again, around 1.5 more times to contract the disease, 3 to 4 times more likely to get hospitalized, and roughly 3 times more likely to actually die from the disease. So we're talking huge disparities, not only on who gets the disease, but then who also struggles from the disease itself. And sorry, I'm trying to get out of the screen here. So when you look at why we say COVID-19 really has kind of laid bare the disparity within healthcare that we knew about, COVID-19 just kind of put it on blast and showed that, listen, we have issues within our healthcare system, and COVID-19 just kind of exposed it. The graph that I showed you from the CDC is widely published, and it's only getting worse as the pandemic spreads. Mm-hmm. Racial and ethnic minority groups are unequally affected by unintended economic and social factors that always existed before the pandemic. I want to take a moment, if you'll allow me, Dr. Kate, to talk about social determinants of health.
Yes, please.
So the reason why, right, because we know the numbers are bad for these groups, but the reason why really looks back to social determinants of health and 5 topics in particular. And underlining these social determinations of health is discrimination. Discriminations which includes harm from racism and associated chronic stress, influenced by these topics I want to go over. So the first is going to be the neighborhood and the physical environment that these groups tend to live in. Let's take a look at Flint, Michigan, for example. Predominantly Black population had lead infused within their waters, and it had terrible outcomes. The likelihood of that happening in a white suburban neighborhood is less likely. We know that minoritized groups tend to live in affordable housing and crowded spacing. These conditions are more likely to increase illnesses, disease, and injuries that are more severe. And then you also have the fact that in some cultures, you have multi-generational members within the same household, so it's more likely to transmit the disease to them. And we also know that the elderly population have poor outcomes with COVID-19. So the physical environment and the neighborhoods that these populations tend to live in is a huge factor. Then let's look at health and healthcare access. So also these neighborhoods tend to be away from hospitals in the first place. But then you also know that these groups are disproportionately affected by the lack of access to quality healthcare and health insurance. On top of that, if you don't speak English, you don't speak English well, the care that you get in the hospitals is not as good. We're not as linguistically and culturally appropriate as we should be within the hospital system. Inequities in treatment may result because of a lack of distrust within the government, right? If you are worried about getting deported, you may not go to the hospital to seek healthcare in the first place. When we look at COVID-19 in particular, another factor that affects this is the occupation and job conditions. So I am a first responder, but I know that when I go into the hospital, I'm going to be exposed to COVID-19 patients. So I have the privilege of getting appropriate protective equipment, right? I get the mask, the N95s. I'm armed before I go in, as I walk into the hospital. When you think about people who work in the transportation industry and who are working the, actually transportation is a big one, but also farm, grocery workers, the ones who do the healthcare or grocery deliveries, they don't have access to the PPE that we as nurses, physicians, pharmacists get. And so they're more likely to have a chance of getting exposed to COVID-19 without the proper protection. Income and wealth inequities, I think that goes without saying how that affects your increased likelihood to get disease. And then lastly, we have education as a huge factor in how people access healthcare and the neighborhoods that they live in as well. So all these 5 factors really affect the disproportionate care that these groups get and increase their likelihood of getting COVID-19.
Thank you. So with all of that said, how do we go about making a systematic change in our healthcare system to help address some of these issues?
That is a really heavy lift. And I wish I had all the answers. And I think part of it I alluded to earlier when I was talking about the clinical trials. So having a diverse participant pool helps us really create more equitable healthcare standards. It helps us take into consideration the different populations that are going to be receiving care. So that's one. But I'll say on a more global level, you can't make systemic change unless you realize there's a problem. Mm-hmm. Over the summer of 2020, we actually had a lot of research institutions, healthcare institutions publicly state that systemic racism affects healthcare. The American Medical Association at their House of Delegate meeting in November actually made that, and they said that it's a public health crisis. So the first step is really to identify that these institutional issues are within the healthcare setting, and that's a problem. Once you can identify that as a problem, then you can take steps to actually fixing those issues. For example, addressing transportation access to the hospital in the first place. You can change the practices within your clinic, within your hospital to equalize access to healthcare and medicine. And the rest of the changes comes within institutions.
So just to summarize your perspective, that racism is really a public health emergency and needs to be treated as such for us to address these systemic problems that we are seeing now.
100%.
Okay, thank you. Another question. How can we better protect people with the COVID-19 crisis? For example, allowing priority access to vaccines for people who may be at greater risk.
So, and this honestly varies state by state. So for example, in California, they obviously prioritize the healthcare workers, people who are on the front line fighting the disease. And it's going to be about mass vaccination and giving people who are at high risk access to it. So for us in California, after we've taken care of all the healthcare providers and all the healthcare workers, we're now in the phase where we're looking at teachers and those who are over 65 of age. But we're not really addressing the populations that I spent so much time talking about in your last question. And that's a tough one. And so what a lot of people are doing with different social media campaigns and just outreach campaigns is that when we get to the stage where we start vaccinating more and more people, is to make sure that those at highest risk trust that the vaccine is safe, trust that it's going to keep you safe and keep you healthy, and that they take it. For example, pregnant women is a population I didn't talk about. If a pregnant woman gets COVID, we know that COVID affects your ability to breathe. Pregnant women are actually more at risk of getting intubated, having to be on a life support machine if they get a bad case of COVID than their non-pregnant counterpart. So I think really it's about a mass education campaign so people know the people who are at high risk of having bad disease outcomes trust that they can get the vaccine. And we do whatever we can. There's different hashtags like this is our shot or hashtag vaccines are safe. And there's so many people. There's one of the people I follow on Instagram. It's called Black Doctors Get the Shot. I follow her and it just shows Black physicians getting the COVID-19 shot so that their patients and other people within that community feel safe and feel comfortable getting the vaccination.
Yeah, what we learn at Patients Like Me is when you can communicate with or see someone who is a patient like me, you can learn so much from their example. And that is a powerful comment that you made. Absolutely.
Dr. K, I actually think that, partnering with Patients Like Me so that if people within their peer group see each other getting the vaccine, that's honestly, I think, even more powerful than a medical expert saying, get the vaccine, it's safe. But if you see someone who is like you getting the vaccine and you see that they have a positive outcome or they don't have any negative side effects, it makes you more likely, it increases that sense of safety and that sense of camaraderie. You can't see me from the waist up, but I'm 33 weeks pregnant, and I actually am telling my story on Twitter, like, hey, I'm a person of color, I'm pregnant, I'm getting the vaccine, it's safe. And it's stories like that from patients, from participants. So it's not us doctors just kind of talking to each other, but talking to the people and other people talking to each other that's going to increase the rate of vaccine acceptance and being delivered.
Thank you. And that's fantastic and just such a good example of what you were commenting on in terms of us learning from one another, from patients like me. And that brings me to my next comments and set of questions. On our site, Patients Like Me, we have many users with various health conditions who are concerned about COVID-19 and how it will impact the quality of their life. And we do have a few questions from users, and perhaps you could answer a couple of these questions. So many of our members are folks with who are immunocompromised in different capacities. Have there been any significant clinical findings concerning outcomes for COVID-19 among patients who have autoimmune disorders?
So I'm going to preface all my answers by saying I'm not a COVID-19 expert, and that always look at the CDC as a trusted site or the NIH website to get more information. But I will tell you, as a physician, I know that patients with autoimmune disease are at baseline, because they're autoimmune, at risk for infectious disease. And this can because of the effect that their disease has on different organ function and makes them more likely just to contract diseases in general. And viruses are no exceptions. It also makes them more likely to have different chronic illnesses that we know COVID-19 is worse for. So for example, patients with diabetes have poorer outcomes. Patients who have hypertension have higher outcomes. So if you have an autoimmune disease and you have different comorbidities, different organ injury, we know that you are unfortunately, more likely to have a poor outcome with COVID-19. It's interesting, though, in the hospital, one of the medications we treat you with when you do get hospitalized are steroids, which we know kind of lower your immune system. So I can see as a patient why you're getting this conflicting information. But if you have an autoimmune disease, you've got to be extra vigilant, right? Wear a mask, stay safe, follow the guidelines. And if you start to feel like you're being sick, you don't feel well, you have those shortness of breath, go to the emergency department. Don't wait, because the longer you wait to get medical help, the poorer your chances are. So if you have an autoimmune disease and you have those early symptoms, please do go to your healthcare provider as soon as possible.
Thank you. Another question. If someone has had COVID-19 and is now recovered, does that add any effectiveness to the vaccine for future protection?
So since we really just started vaccinating at the end of 2020, I don't think we have enough data to really answer that question specifically. But what we do know, what we do have data on, is that reinfection is still possible once you have COVID-19. So once you have COVID-19, it's possible to get it again. And just because you get it again doesn't mean that you have a mild disease. In fact, we've had patients who've gotten twice and ended up on the ventilator. So it can still cause severe medical complication. The recommendation is that even if you've already had COVID-19, get the vaccine. You want to wait. So if you've had COVID-19 and it's diagnosed, you want to wait at least 90 days after you're asymptomatic from your diagnosis to then start the vaccine series. And so far with Pfizer and Moderna, they're both two-shot vaccine series. With Pfizer, it's about 3 weeks in between. And with Moderna, it's about 4 weeks in between. So even though you've had it, we're still really pushing for you to get the vaccine, because you can still get reinfected with COVID again.
Okay, that's great. So another question, one of our members wrote to us that her daughter had COVID-19. The question is, how long will her daughter be immune, and do her family members need to wear a mask around her after her recovery?
That's a really good question. So how long is she immune after she's had COVID-19? Simple answer is we don't actually know, right? We don't know how long that immunity lasts for, because again, we know that you can get reinfected. So we're still kind of sorting that out. So I don't know the answer to that. But how long should people wear a mask around her? So if she's still within the household and she had COVID-19, everybody within the household should quarantine for at least 14 days after she's asymptomatic. I would say if you guys were all living in the same household and you had the disease, you probably all were exposed if you weren't wearing a mask in the first place. But as far as to like how long you want to wear a mask around her, I think the safest thing is you want to wait until she is asymptomatic, retested, and has a COVID negative test. Until you get that second COVID negative test, wear a mask around her. But you still want to be, honestly, as a family, isolating to protect other people from that exposure as well.
Okay, great. Thank you. Now, another question has come up about accurately counting the number of people worldwide who have had COVID-19 and have died as the result of the pandemic. So the question is there anything being done to improve or standardize the counting methodology in regards to understanding the total number of afflicted individuals from a healthcare perspective?
That's kind of like public health.
Right.
So the short answer is what we know works is contact tracing. So test, find out who tested positive, and then find out who that person was exposed to, and then test those people, right? So there's a clear standard. We know that's the best way to do it. We know that countries like South Korea have done an excellent job of this. It's actually also how they're able to get the disease under control. Japan also has great outcomes. We within the United States haven't been able to get it under control. And a lot of it is because of the testing and the contact tracing.
Mhm.
So the answer is we know what to do and we know how to do it. It's the different levels of support, because could you imagine how much healthcare workers you have to be able to do all that contact tracing and testing? So you have to have the resources and the infrastructure, which I will say, I think with the new administration coming, there's going to be more resources provided to kind of hold that infrastructure up to be able to do this. But it's going to take some time. And unfortunately, with the new variant within the United States, it's going to be, we have to just be faster with it. So to answer your question, are there things being done to improve this? Absolutely, because we know what needs to be done. It's just, I feel like the answer to any question is always money, right? It's just going to take time and money to put those infrastructure in place, especially within the United States. There's some countries that are doing it that have done a great job until we have accurate numbers. It's just different places have different resources and ability to kind of launch those kind of public health campaigns to address that.
Great. Okay, another question about COVID-19 is, what is the likelihood of developing an infection from a COVID-19 infection from someone who is asymptomatic, so an asymptomatic carrier, versus someone who is obviously very sick?
So again, not an expert, but I'm going to use common sense and what I've seen in the hospital. So if someone is very sick, they're more likely to be able to transmit the virus to you via their sputum, right? It's not necessarily like they may have the same viral load, but they may just be expectorating secretions that get into you, so you're more likely to get it. That said, I've definitely seen patients who've been hospitalized who live with someone who's asymptomatic, didn't even know they didn't know they had it, and then unfortunately their loved one got really sick from it, hospitalized, and didn't have a great outcome. So are you more likely to get it from someone who's very sick? Probably, because they're more likely to be secreting the virus, but somebody who's asymptomatic may have the same viral load as somebody who doesn't. It's kind of crazy. I would just say the simple answer is just be on the safe side and wear your mask.
Definitely. So another question, are there lasting effects after recovery from COVID-19?
Yeah, so there's actually more and more papers being published about what they call long haulers in the COVID-19 community. So those who've had it really recovered are, from the large part, asymptomatic, but then have these lingering effects of the disease. There are things that happen with patients' toes, different sensitivities. So there are some patients, and again, we don't know why some patients have this lingering effects. We don't know why some patients just take longer to recover from the disease. But we do know that there's a subpopulation. You guys can look it up on PubMed or any scholarly article, but they're called COVID long haulers, who just have these lingering effects. And it's not, so far it doesn't seem to be tied to any underlying conditions that they have. We don't know yet.
Okay, that's great. And another question that came up was around the vaccine and how often should people get the vaccine in the future?
So we don't know that yet. So for example, we know that for the flu, you get it every year, correct? You should get the vaccine every year. I know that right now, the virus, there's still going to be variants of the virus. Right now, the Moderna and the Pfizer, as far as we know, is effective for the different variants. And right now, the recommendation is you complete your 2-shot series. So again, if you get the Pfizer vaccine, it's 3 weeks between the shot. If you get the Moderna vaccine, you wait 4 weeks. So it's 2 shots to be fully vaccinated. And for right now, the recommendation is you just get that series, that one time. Will it be an annual thing? I don't know that we know that yet. At least I don't know the answer to that yet.
Yeah, I know as an emergency physician by training, we all, of course, obtain the flu vaccine annually. And we were wondering if this would become another vaccine like the flu vaccine into the future, where we may receive the vaccination annually to keep ourselves safe and those around us, of course.
For a lot of reasons, I certainly hope not, because I think we've seen how much more severe this virus is than the annual flu. So I certainly hope that this will be more in the line of polio and measles, that once you complete those childhood vaccination series, that you're good to go. And so I think our hope, I know our hope as a medical community is that once we get this mass vaccination, this one time, that would be it. But we just don't know, which is why we're still recommending, even if you're fully vaccinated, still wear a mask. And I can tell you, my colleagues who've completed their 2-shot vaccine series, who work in the hospital, we were still masking up. We're still wearing N95s. We're still getting up before we go in to see patients, and we're still wearing those face shields. So get vaccinated, but still kind of wear that mask. Our hope is that the more people get vaccinated, the more we can lower our lockdown protocols and start to get back to normal life and actually just be a community again.
Definitely. And I think that that's a fantastic message, which is even after we receive our vaccinations, that we are going to be wearing our masks, social distancing, until our scientists like yourself, physicians like yourself, have enough data to establish that we can change the practices we have all adopted to stay safe and healthy during the pandemic.
Absolutely.
Yeah.
And I know that we're getting close to the top of the hour, so I just wanted to go back and hit a point. Sure. That when we look at people who are more susceptible, when we look at our minority groups who are getting affected worse with COVID-19, it's not because of anything biological. It's because of existing problems within our healthcare system that COVID-19 kind of just, again, put on blast, made it more obvious. It's those key social determinants of health, and it's systemic and institutionalized racism within the healthcare system that's made it so much worse for these patient populations. And it's important, very, very important, that we get a diverse amount of patient populations participating in clinical trials. The more information we have from a diverse group, the better our treatments can be, the more targeted our healthcare can be, and the better health we can provide for everyone.
Thank you so much, Dr. Ajayi, for joining today's webinar and talking about such incredibly important topics. We'd also like to thank our viewers for tuning in. And if you're interested in learning more about what we talked about here today, you can go to the All of Us Programs website to learn more about the program. And Patients Like Me will also be hosting a follow-up Q&A discussion to address any other questions that our members may have about this important topic. Thank you so much.
Thank you for having me. It's been a pleasure.
And Dr. Ajayi, could you just tell us about the All of Us research program?
Absolutely. I don't want to get too technical because it really is a simple and easy program to join that as many people can join as possible would be great. So All of Us is a research program from the NIH, the National Institute of Health. And really our goal is to enroll 1 million or more people from across the US and to get as diverse a patient population as possible to really help speed up medical research. So again, the more diverse patient population we have joining All of Us, the better. So people who join will share their information about their health, their habits, and what it's like where they live. So for us on the research side, we look at this data, and by looking at the patterns, we're able to learn more about what affects people's health. It's really that simple. And you can share as much or as little as you want. You can go to the Join All of Us website. You can download the app on your phone if you want to use your computer, whichever way. Your data is completely de-identified and it's protected. And so researchers will look at the data that's provided and then really try to answer questions on a population health level to really drive better healthcare. And that is the All of Us program.
Thank you, Dr. Ajayi, for telling us all about the All of Us research program.
Absolutely.